So we will be studying about approach to shock, right? Now, patient presents with signs and symptoms. Patient presents with sign and symptoms of shock. First of all, we will be doing A, B, C, D, E assessment, ASS, ESS, right? Now, then we'll go for the acute management, right? What will be that? We'll stabilize airway, breathing, and circulation, right? Now, then we will obtain IV access, right? And then we will be giving fluid resuscitation, right? Resuscitation. And then sometimes central venous catheter may be needed, arterial catheter may be needed, or peripheral arterial catheter can needed be needed. So we'll be doing vital sign monitoring, right? Now, we'll be doing focused history and physical examination. Okay, and then labs. So what will be the history? The history will be weakness, fatigue, lethargy, postural dizziness, right? Then on physical examination we will be having hypotension, weak peripheral pulses, right? Tachycardia, and AMS, right? Basically that means altered mental status, right? Now we'll do basically assess the skin temperature and assess skin temp temperature and CRT, right? Now capillary refilling time. So we can have two possibilities, right? First of all, it can be warm, dry, flushed skin, plus and minus normal CRT, right? So here we will be consider distributive shock, right? Now, if the history is basically what, brain or spinal cord injury, physical examination will show bradycardia, neurologic deficits, paralysis. Example: paralysis, paralysis, right? So we will consider neurogenic shock. Then we will do imaging, which will be basically CT, right? So here we can have skull or vertebral fractures or intracranial bleeding, right? Or spinal cord injuries. So we will make a diagnosis of neurogenic shock, right? Then if the history is basically what, known or suspected trigger, example: food allergens, insect stings, bites, right? Now, on physical examination, we can have what, urticaria, itchy skin, then labored breathing, wheezing, stridor, right? So we will consider anaphylactic shock. So now we will see plus or minus tryptase, right? So tryptase, if elevated, it can be plus or minus elevated. So we'll consider anaphylactic shock, right? Then now history sometimes can be fever, symptoms suggestive of what, infection. Okay, now physical examination can have signs of infection. Okay, labs can show what? Leukocytosis, leukocytosis, thrombocytopenia, elevated lactate, elevated inflammatory markers like what? ESR, CRP, procalcitonin. So we'll consider what? Consider sep- septic shock. Right now we'll be doing blood cultures, right? Then imaging, chest x-ray, CT. Okay, if blood cultures is positive and here imaging can show source of infection, right? So we'll say it is septic shock. Now we'll go to back to the story here. If when assessing the skin temperature and capillary fill time, if it is otherwise than the warm, dry, flushed skin, we'll think of these three diagnoses, right? Then if it is what? Mm, if it is cold, clammy skin, delayed capillary refill time, right? Now we will assess for evidence of volume loss. Now there can be two possibilities. First of all, there can be blood loss or dehydration. Okay, now we'll consider what? Consider hypovolemic shock. Now then here we can have two possibilities, right? If the history is trauma or bleeding, hemati hematemesis, hematemesis, melena, hematochezia, and CBC shows what? low hemoglobin, that is bleeding. Now we'll be considering what? Consider hemo consider hemorrhagic shock. Now we'll be doing US and CT, right? EG, D, and colonoscopy, right? And then we'll do imaging, bleeding source visualized. We'll say hemorrhagic shock. If the history is what? Vomiting, diarrhea, burn. Now physical examination, decreased skin turgor, dry mucous mem- membrane, decreased UO. Now CBC can show high hemoglobin, right? Hemoconcentration, right? Now we will be considering what? Consider non hemorrhagic shock. Then we will be doing SS organ system for cause. So diarrhea, vomiting, then it can be IBD, GI infection. Now severe blisters, HR, right? Due to burns. So non hemorrhagic shock. So now if this line is extended, Sorry for any disturbance. That means now no evidence of blood or fluid loss. So here we have two conditions, right? Consider cardiogenic shock, right? Here just let it be. So first of all, cardiogenic shock, right? Now labs cardiac, if we are suspecting consider or considering cardiogenic shock, cardiac enzymes BNP ECG, right? Imaging, that is TT, right? Here I can have two possibilities. History, if history is shortness of breath, fatigue, right? Physical examination shows what? Peripheral edema, crackles, crackles, JVD, right? Labs show elevated BNP. TTE shows what? Ventricular dysfunction. So heart failure, right? So if the history is what? Squeezing, substernal chest pain. Okay, now on physical examination, patient shows diaphoresis and ECG shows plus or minus ST elevation. Labs show what? Elevated cardiac enzymes, right? So we'll be considering myocardial in infarction, right? Now the second case scenario is that we will be considering obstructive shock, right? So what are the labs? D-dimer imaging, labs will be showing D-dimer imaging, chest x-ray, TTE. Now here we have three possibilities. First of all, we will be seeing history. If history of the patient is blue, pleuritic chest pain, hemoptysis, hemoptysis, and DVT, right? On physical examination, tachypnea, unilateral leg swelling, right? Now labs show elevated D-dimer. Now we'll see Wells score imaging CTPA. Now if the Wells score is greater than 2, CTPA filling defect. So we'll be considering about pulmonary embolism. Embolism. Okay. Now if the history is what? Chest pain, relieved by sitting up or leaning forward. Now on physical examinations we can have what? Beck's triad. That is basically what? Hypotension, JVD, and muffled heart sounds. Okay. Now then we will be doing imaging CTPA and TTE, transthoracic echo, and CTPA, chest x-ray, wide mediastinum, water bottle sign, and TTE we have pericardial effusion, then R A R V collapse, then that we will be considering cardiac tamponade. Now if the history will be sudden, severe chest pain, SOB, on physical examination, shallow shallow breathing, tachypnea, absent breath, sounds on affected side, then tra- tracheal deviation towards opposite side. So I will be tension pneumo pneumothorax, right? So these you have to keep in mind: tension pneumothorax, cardiac tamponade, and pulmonary embolism. These are the basically what no evidence of the blood loss. Considering obstructive shock, in cardiogenic shock we can have heart failure or myocardial infarction. Here blood loss or dehydration we can consider hypovolemic shock. There we consider hemorrhagic shock and non-hemorrhagic shock. And these are into the cold clammy skin, delayed CRT. If warm dry flushed skin and normal CRT, will be looking for the neurogenic shock.